Today we're diving deep into a comprehensive review of maternity and newborn care, based on a detailed HESI and NCLEX-style question bank. This is for clinicians and advanced students looking to sharpen their clinical reasoning around complex maternal, fetal, and newborn scenarios.
Yeah, it's a hefty one, but really important stuff. We'll cover high-risk pregnancies, fetal monitoring nuances, newborn complications, postpartum emergencies, and key newborn assessments. The goal is to unpack the rationale behind critical clinical decisions and deepen our understanding of the underlying pathophysiology and management.
Exactly. So let's start with high-risk pregnancy and hypertensive disorders. Preeclampsia is front and center here. It's a hypertensive disorder characterized by new-onset hypertension and proteinuria after 20 weeks gestation. What's interesting is how multiple gestation plays a role as a risk factor. The increased placental demand and vascular stress really push the maternal system.
Right, and that's often overlooked. People think of preeclampsia risk factors as just maternal age or chronic hypertension, but multiple gestation is a big one because the placenta's workload is essentially doubled or more. That vascular stress can tip the balance toward endothelial dysfunction.
And when we talk about severe hypertension in pregnancy, the clinical threshold is a blood pressure of 160/110 or higher. That's a red flag requiring urgent intervention. It's not just numbers, it's about preventing progression to eclampsia or other complications.
Absolutely. And the signs of worsening preeclampsia are critical to catch early. Persistent headache and blurred vision point to central nervous system involvement. That's when you worry about imminent seizures or eclampsia.
Which brings us to magnesium sulfate. It's the go-to medication for seizure prophylaxis in severe preeclampsia and eclampsia, but it's a double-edged sword because of its narrow therapeutic window. Monitoring for toxicity is essential. Loss of deep tendon reflexes, respiratory depression, and decreased urine output are key signs.
Yeah, and having calcium gluconate readily available as the antidote is a must. It's one of those safety nets that can't be overlooked. I always think of magnesium sulfate like a powerful tool that needs careful handling.
Same here. And just to clarify, eclampsia is defined as seizures in a patient with preeclampsia, not explained by other causes. So it's a progression, not a separate condition. MCHAs.
And then there's HELLP syndrome, which is a severe variant of preeclampsia. Hemolysis, elevated liver enzymes, and low platelets. It's systemic and can be life-threatening. So early recognition is vital.
Moving on, gestational diabetes mellitus is another big topic. The common fetal complication is macrosomia, which obviously complicates delivery. The first-line management is diet modification, glucose monitoring, and exercise before jumping to medications.
Right, and that conservative approach often gets overlooked in favor of pharmacologic treatment, but lifestyle interventions can be very effective initially.
Then we have placental complications. Placenta previa typically presents with painless bright red vaginal bleeding because the placenta covers or is near the cervical OS. In contrast, placental abruption involves painful bleeding, uterine tenderness, and fetal distress due to premature separation.
The distinction is crucial because management differs significantly. Placenta previa often requires cesarean delivery, while abruption is more emergent due to fetal compromise.
Speaking of the placenta, the umbilical cord anatomy is fascinating. Normally, it has one vein carrying oxygenated blood from the placenta to the fetus, and two arteries carrying deoxygenated blood and waste back to the placenta.
And Wharton's jelly is the unsung hero here. It cushions and protects those vessels from compression. I like to think of it as the cord's natural shock absorber. Without it, cord compression would be a much bigger problem.
That ties into fetal heart rate monitoring. Variable decelerations are classic for umbilical cord compression, and if cord prolapse is suspected, the priority is maternal positioning, knee chest, or Trendelenburg to relieve pressure. Importantly, the nurse should never attempt to push the cord back in.
That's a critical safety point. Trying to replace the cord can cause more harm. Positioning buys time until delivery can be expedited.
The placenta itself is multifunctional. Gas exchange, nutrient transfer, waste removal, and hormone production, including HCG, estrogen, progesterone, and human placental lactogen. That last one, HPL, increases maternal insulin resistance to prioritize glucose availability for the fetus.
Which explains why gestational diabetes develops in some pregnancies. The maternal metabolism shifts to favor the fetus, but sometimes that leads to hyperglycemia.
Shifting gears, let's touch on pregnancy signs and obstetric notation. Presumptive signs are subjective symptoms like amenorrhea. Probable signs are objective findings such as Chadwick sign, bluish discoloration of the cervix and vagina, Goodell sign, which is cervical softening, and Hagar sign, softening of the lower uterine segment.
And positive signs are definitive evidence of the fetus, like fetal heart tones heard by Doppler. It's important to differentiate these because they guide clinical suspicion and diagnoses.
On the topic of GTPAL, it's a concise way to summarize obstetric history: gravida, term births, preterm births, abortions, and living children. For example, G4T1P1A1L2 means 4 pregnancies, 1 term birth, 1 preterm birth, 1 abortion, and 2 living children.
That notation can be confusing at first, but it's invaluable for quick clinical communication.
Now, fetal assessment with the biophysical profile, or BPP, includes fetal breathing, movement, tone, amniotic fluid volume, and the non-stress test. Each category is scored 0 or 2 for a total out of 10. Scores of 8 or 10 are generally reassuring, especially if amniotic fluid is adequate.
And it's worth noting that maternal cervical dilation is not part of the BPP, which sometimes trips people up.
After rupture of membranes, fetal heart rate monitoring is a priority to detect cord compression or prolapse. That's a critical window for fetal compromise.
Moving into newborn care, breastfeeding contraindications include maternal HIV infection, where safe alternatives exist due to transmission risk. Untreated active tuberculosis may require temporary interruption of breastfeeding until treatment reduces transmission risk.
HIV management in pregnancy is another key point. Antiretroviral therapy during pregnancy, labor, and for the newborn reduces perinatal transmission risk significantly.
Newborn hypoglycemia risk is elevated in infants of diabetic mothers because of fetal hyperinsulinemia. That's something to monitor closely after birth.
Hyperbilirubinemia is another common newborn complication. Risk factors include blood group incompatibility and cephalohematoma. Early signs are yellowing of the skin and sclera. Assessment includes blanching the skin to detect jaundice, especially in darker skin tones.
Bilirubin levels can be measured via serum or transcutaneous methods. Frequent feeding promotes stooling, which helps eliminate bilirubin naturally. Phototherapy requires eye protection, and the diaper may be removed to maximize skin exposure.
And acute bilirubin encephalopathy, or kernicterus, presents with lethargy, poor feeding, and a high-pitched cry. These signs require urgent intervention.
On Rh incompatibility, it occurs when an Rh-negative mother carries an Rh-positive fetus. Rho immune globulin prevents maternal sensitization and is administered around 28 weeks and within 72 hours postpartum if the infant is Rh positive.
Cold stress in newborns is another important topic. It leads to increased oxygen and glucose consumption, risking hypoglycemia and respiratory distress. Prevention includes drying the newborn thoroughly and skin-to-skin contact. Newborns have limited brown fat stores and immature thermoregulation, making them vulnerable.
Postpartum complications are next. A boggy uterus with heavy bleeding indicates uterine atony, the leading cause of postpartum hemorrhage. The priority nursing action is fundal massage to stimulate contraction. Oxytocin administration promotes uterine contraction and reduces bleeding.
Excessive bleeding, like saturating a perineal pad in 15 minutes, requires immediate reporting. Severe hemorrhage can lead to hypovolemic shock, so early shock assessment is critical.
Postpartum infection signs include foul-smelling lochia and fever with uterine tenderness, suggesting endometritis. Prolonged rupture of membranes increases infection risk.
And unilateral calf pain and swelling postpartum should raise suspicion for deep vein thrombosis. Early recognition is key to prevent complications.
Neonatal abstinence syndrome, or NAS, is primarily caused by in utero opioid exposure. Symptoms include tremors, high-pitched cry, irritability, and poor feeding. Management involves minimizing stimulation with swaddling and a quiet environment. Feeding difficulties are common due to poor coordination and vomiting.
Torch infections include toxoplasmosis, other infections, rubella, cytomegalovirus, and herpes simplex. Congenital rubella syndrome can cause cataracts and cardiac defects, while CMV may cause hearing loss and neurologic impairment. Prevention includes avoiding undercooked meat and cat litter exposure for toxoplasmosis.
Newborn medications include vitamin K prophylaxis to prevent hemorrhagic disease, administered intramuscularly shortly after birth. Erythromycin eye ointment prevents ophthalmia neonatorum from gonococcal infection. The hepatitis B vaccine protects against hepatitis B infection, and infants of hepatitis B positive mothers receive both vaccine and HBIG for passive and active immunity.
EPGAR scoring is performed at 1 and 5 minutes after birth, assessing appearance, pulse, grimace, activity, and respiration. Scores between 7 and 10 are generally reassuring. The pulse component specifically evaluates heart rate.
Newborn reflexes are also important. The rooting reflex causes the infant to turn toward cheek stimulation, aiding feeding. The Moro reflex is a startle response to sudden loss of support or loud noise. The Babinski reflex causes toes to fan outward when the sole is stroked and is normal in newborns. Absence of the Moro reflex may indicate neurologic or brachial plexus injury.
Preterm labor risk increases with infections like urinary tract infections. Preterm labor is defined as regular contractions with cervical change before 37 weeks. Dexamethasone is administered to accelerate fetal lung maturity by promoting surfactant production. Tocolytics like nifedipine may reduce uterine contractions, and magnesium sulfate is used for fetal neuroprotection, reducing cerebral palsy risk in very preterm infants.
Newborn head conditions include caput succedaneum, which is generalized scalp edema crossing suture lines caused by pressure during labor. Cephalohematoma is bleeding beneath the periosteum that does not cross suture lines and is associated with increased bilirubin risk. Molding refers to overlapping cranial bones to facilitate passage through the birth canal and is normal and temporary.
Finally, critical newborn assessments. Respiratory distress signs like tachypnea with grunting require urgent attention. Kick counts fewer than 10 movements in 2 hours should be reported as potential fetal compromise. Acrocyanosis, bluish hands and feet, is normal immediately after birth, but central cyanosis is concerning. Hypothermia, such as a temperature of 36.1 degrees Celsius, is dangerous and requires prompt intervention. Strong suck and coordinated feeding are reassuring signs of neurologic adaptation.
That was a lot to cover, but I think the key takeaway is the importance of early recognition and appropriate intervention across the maternal and newborn spectrum. Understanding the pathophysiology behind these conditions really informs our clinical decisions.
Absolutely. And keeping a close eye on subtle signs, whether it's worsening preeclampsia symptoms, fetal heart rate patterns, or newborn reflexes, can make all the difference in outcomes.
Thanks for joining us in this deep dive. We hope this discussion sharpens your clinical reasoning and supports your practice.
Take care, and until next time.